Good morning, everybody. Thank you so much for joining. We'll give a few minutes for some more people to filter in, and then we'll go ahead and get started. Okay, so it's promptly 10 o'clock, so I think we will go ahead and begin. So good morning to everyone, or good afternoon, and thank you very much for joining today. We welcome you to today's webinar, which is hosted by Hepatitis Delta Connect at the Hepatitis B Foundation. My name is Beatrice Ovich, and I'm a Public Health Program Manager at the Hep B Foundation and the Manager of Hep Delta Connect. Thank you all for tuning in today. Today's webinar is focused on the case for conducting double reflex testing for hepatitis delta for all individuals who are living with hepatitis B, and for the importance of this testing. We will have an opportunity today to hear from Dr. Devin Razavi-Shearer of the Center for Disease Analysis Foundation, who will make the case for the necessity of this type of screening, and we'll discuss some recent work that has been done to establish clearer estimates of hepatitis delta prevalence globally. We are looking forward to a great presentation today. Next slide, please. So before we begin, just a quick note on how to participate in Zoom webinars. I would just like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. If at any time during the presentation you have questions, you can feel free to please enter them into the Q&A box. Questions will be addressed by Dr. Razavi-Shearer at the conclusion of the presentation, and this session is also being recorded and slide presentations will be shared following the webinar. Next slide, please. Thank you. So just a quick overview of our Hepatitis Delta Connect program. This is a dedicated program of the Hepatitis B Foundation, and it was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and for promoting diagnosis, screening, research, and linkage to care, as well as providing support for individuals living with and affected by hepatitis delta through a variety of channels, including email and phone consults, social media, newsletters, blog posts, a website, and webinars such as this one. We also run hepatitis delta-focused events and lead HDV public health research projects. We are hoping to continue to build and expand our programming in the coming years, and we'll keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you. So today we're really excited and honored to be joined by Dr. Devin Razavi-Shearer, who is the Associate Director of Hepatitis B and Delta Projects at the Center for Disease Analysis Foundation. Dr. Razavi-Shearer has been leading these projects since their inception at the foundation, and he worked with the modeling team at CDAF to develop the PROGRESS model, which is a fully dynamic hepatitis B transmission and disease progression model with immigration and economic impact modules. He also led CDAF's previous work with the Vaccine Impact Modeling Consortium, which is the group that models the impact of vaccination for Gavi, the Vaccine Alliance. Dr. Razavi-Shearer also has a lot of experience in managing device clinical trials, as well as study design with data analysis of both prospective and retrospective studies. We're very excited to be joined today by Dr. Razavi-Shearer and are grateful to him for joining us. We invite audience members, again, if you have any questions throughout the presentation, to please put them in the Q&A box as they arise, and we will address them at the conclusion of the talk. And without further ado, I invite Dr. Razavi-Shearer to begin his presentation. Thank you so much.
Thank you so much, Beatrice. Thank you all for being here, and of course, Hepatitis B Foundation and all the amazing work that you all do every day. It's truly a pleasure and honor to be here. I'm going to start sharing my screen. There we go. So today, what I'd like to review with you all is I'll give a really quick background about our organization, the Center for Disease Analysis Foundation. And then I'll be going through the basic epidemiology of what we found for hepatitis B, Delta, which of course leads into the case for reflex testing. So here at Center for Disease Analysis Foundation, we host the Polaris Observatory, which is a free database online for everyone to use that shows the impact of vaccination, treatment, and diagnosis on the future burden of hepatitis B and C. And we also estimate when countries will meet WHO targets or if they will meet them. And we work with countries to do all this data analysis and collection. So thus far, we've worked with over 132 countries personally, and then we also have additional models as well that are based on extrapolated data. But we try to work with as many countries as possible to really understand what's going on in the country, as oftentimes they have better information than may be reported in the literature, which is a point we'll of course come back to regarding Delta. So for today, as I said, we're going to first just very briefly touch on hepatitis B, because of course that is a very impactful, and on Delta, as you can only have Delta if you have B, and then we'll move into Delta and reflex testing. So recently we just published with our esteemed collaborators a new estimate for hepatitis B prevalence, which is about 258 million individuals are hepatitis B positive, representing a prevalence of about 3.2%. Of course, unfortunately, less than 15% are diagnosed, and less than 8% of those that we believe are eligible are currently under treatment. So of course, this means there's a lot of work to go. Now, one interesting point to make is that less than 5% of all of the infections in the world occur in high-income countries. So this burden, as you see here on this graph, the burden is really borne by the middle-income countries most, so upper and lower middle-income countries, which means whatever plans we have as far as how to do elimination, as well as what guidelines should be, need to be simple enough that these countries can implement them. Now, recently, also this year, we published a study looking at the impact of immigration in the United States on the prevalence of hepatitis B. So here on the left, you have the top 20 countries of source countries for immigrants getting their green cards in the US, so lawful permanent resident status. And on the right is the countries ranked by the number of hepatitis B immigrants we believe are currently living in the US. So as you see, even though there's a lot of immigrants from Mexico, they actually have a very low prevalence. So they dropped to number 19 inside of total B cases, whereas there's other countries, of course, that are able to overcome, Vietnam even overtakes India at the national level. And this resulted in our estimate of about 0.55% prevalence in the US. So increasing the NHANES from 0.82 million to about 1.8 million immigrants. Now, we also did a similar analysis that we published with Switzerland and found that the prevalence in Switzerland was about twice of the base estimate of what their Federal Office of Public Health was estimating, and over 80% are foreign-born. This is very important when we get to Delta, as in many Western countries and high-income countries, a large portion of the Delta burden is among the immigrant communities. And so we need the same tools and resources that we use to screen those communities and link them to care, not only for hepatitis B, but also to be able to use those for Delta. So what do we know about Delta, and how did we come to these conclusions regarding the Center for Disease Analysis Foundation work? So a little over a year and a half ago, we started a project looking at Delta. So as with all of our studies, we first run a literature review to look at what the studies are, and then we meet with the experts to better understand the studies. So what's important with Delta is really understanding where the data is available in the country. So at what level? So for example, some countries have very good risk factor data, some have good regional data, and some have good clinical data. So we really need to understand the data that's available and then tailor our analysis by what the country has while using any and all data sources. Now, we also went further than just taking the anti-HDV prevalence, but also looked for RNA positivity and tried to adjust to really understand those patients who are most in need of treatment and quantify that. So based on what our initial analyses, which we will be looking to publish later this year, is that there's very few quality studies in most countries representing Delta. Almost all studies take place in diagnosed patients, and oftentimes they're hospitalized. So we know that symptomatic patients have a higher probability of being infected with Delta because, of course, they're progressing faster than your mono-infected hepatitis B patient. And we also know that there's quite high rates among cirrhotic individuals, about 15 to 30% prevalence among hepatitis B, people living with hepatitis B who also have cirrhosis. And also we know patients looking for reimbursement have a higher prevalence than what we'd expect at the national level in the total population of hepatitis B infected. We know, of course, that vaccination for hepatitis B has really helped reduce the number of cases for Delta. However, there are still age groups that weren't vaccinated, and they are continuing to face a large burden in many countries. And then, of course, as we already spoke about, the regions. Now, when countries do a national serosurvey, it's often quite low, the prevalence among people living with hepatitis B, so almost always 1% or lower. But part of the problem we run into with Delta is that there's really large variation in the quality of the anti-HDV tests, which is part of why later when we get to it, some of the RNA numbers jump around quite a bit, as it's really often a reflection of the quality of the Delta tests that they were using for the antigen. While some countries are doing reflex testing at a hospital level, a university, or even a regional level, no countries that we worked with were doing reflex testing at the national level, but all stakeholders were very interested in pushing for this. So, of course, to just dive into the data a little more, what we found is, of course, everyone knows the Amazon region has a very high prevalence of B, and it also has a high prevalence of Delta. So in Brazil and Colombia, we found that the Amazon region was, of course, where this was where the epidemic was. In Western Europe, as we talked about, immigrants have a high burden, as well as the high-risk groups that were born prior to the advent of vaccination and the all other groups. Now, of course, the good thing is that Delta does appear to be decreasing as a result of vaccination. There could be some increases in the high-income countries that started with a very low baseline prevalence of Delta and are impacted by immigrants. So, we've really already touched on much of this, but of the current meta-analyses that are out there, their prevalence was about 5 to 15%. And a lot of this was based on using these studies that we discussed that are skewed, because when you want to do a study, you want to make sure that you'll have good findings that are publishable. And this means that the groups most likely to have hepatitis Delta are those most likely to be studied and then subsequently published. Now, important thing not only for Delta, but just for data analysis in general, is that the crude prevalence that's reported is never the same as population prevalence. So a perfect example of this was this national serosurvey that was done in Brazil Lago 2018. So they found a prevalence of 3.2% of anti-HDV, and this was really their lead. So we looked at the estimates, and we of course said, wow, that is quite high for a national level Delta prevalence. Now the problem is they didn't weight it by age or by region. And so what we see here is that the north, where the Amazon is, has an extremely high prevalence, which is what we'd expect. However, when that's 28 of all of the cases. So there was 40 co-infections and 28 of them came from the north. And so that's where the Amazon, where we'd expect, had 8.5, whereas the major population centers, the south and the southeast, were much lower, a 0 in the south, 1.7. And what we also see here from this study is that prevalence is dropping by age in Brazil, where it's lower in the older populations as a result of mortality. And once again, this high prevalence is really coming from the Amazon region, where timely birth dose is not available, and there continues to be a large hepatitis B problem. So when we took this 3.2% prevalence and adjusted it by the actual population and then by the hepatitis B infected population in these regions, we came out with 1.7%. So this is using the exact same study. The prevalence was almost cut in half just by weighting by regions, as opposed to taking 40 divided by 1,240 by actually weighting the prevalence by the population and the infected population. Now, national registries are fantastic sources of information, but we also know that these are biased. And why they're biased is what you see here is in the general population, you have a lot of hepatitis B infections, which is everything within that red circle. And then there's some Delta infections in as well. But the only people who are currently really being tested are those who are currently under care, so that already there you have a higher prevalence of Delta among the B-infected population. And then only those who are suspected by a clinician are tested for Delta. So this is actually, there's a further concentration of individuals. So what you end up with in national registries, while this is often the largest data source in a country, it's often higher than what you'd actually expect to see at the population level. Now, this is from an old NAFLD study, but what can be a problem with meta-analyses is they can, in this study, 6 of all of these studies that were included actually came for the same source, which was NHANES. It was just the way they interpreted and applied the data that resulted in it. And as you can see, if we included that Lago study from Brazil at 3.2% prevalence, whereas weighting it properly would come up with 1.7%. It's really, meta-analyses have a great use to better understand many things, but in epidemiology, they can be quite dangerous, as well as in other fields, as if the studies are not very comparable and their populations are not comparable, you can end up having the best and the worst case scenarios, and they don't always average out to the mean. Now, this was a study from Italy, which is really interesting about the changing patterns. So here you see the ages, so 0 to 29, and then different years of a study. So going from 1987 to 2019. And we see that the prevalence is drastically dropping, or among the younger age groups, of course, as a result of vaccination. So this is great news. However, the prevalence among people born abroad, although it was only first examined in 2001 and then later was drastically increasing. So this is showing that important impact of immigration. And what was even more interesting is that the average age of the Italians being diagnosed was 55, while for immigrants it was 25. And this is really a result of vaccination being started so much later in sub-Saharan Africa, so about 2001, and with much of those countries still not having access to timely birth dose, they've maintained a higher B prevalence and the Delta transmission occurring within that as well. So that was what we already covered. So to finally get into some of the actual data, so this is the anti-HDV prevalence, and these are some of the countries that we analyzed. So the light blue is the estimates we came to, and the dark blue are from the most cited meta-analysis, which is the Stockdale. So as you see, in many of these countries, so Brazil, we know it was regional. Japan, this was also a regional, that the only main study came from a region that's known for a high prevalence. Romania, this was a result of most of the studies being in patient groups. And then in the US, there's a lot of contradicting data, and so we can get there. But as you see, overall, not only do we generally see lower prevalence estimates, but also we're able to quantify the prevalence in many more countries by sitting down with these countries and talking to the experts, the Ministry of Health, to better understand what they know and what the limitations are of that data. So this is from our literature analysis. Where we started out is the dark blue, and the light blue is where we ended up. So as you see, in almost every case, we dropped. Some remained relatively the same. Many of the East Asian countries actually had very large studies and very low prevalence. But this is partially due to the fact that they have large B infected populations and are better able to find large cohorts of B infections to analyze. So what we've seen is pretty drastic decreases in the anti-HDV prevalence after reviewing the data with experts and weighting by the most appropriate measure. Now, this drops even more. This is the same graph as the last one, except now the yellow is RNA positive. So in most countries, you're already seeing a large drop. And then when we actually look at those requiring treatment, the number is significantly lower once again. And these are, of course, the population that we should be focused on. As we said, of course, hepatitis delta is decreasing globally, which is great news, along with B. However, of course, we need to ensure that those who have been previously infected or those who still are getting infected with delta are able to access the screening and linkage to care and treatment that they need to continue to live healthy lives with their families. Now, finally, what we all came here for, reflex testing. So this is a sort of simplified schematic, but this is generally how things work currently in the US. So a patient comes to a doctor and the doctor suspects someone of having hepatitis B. So they draw the blood, they send it to the lab. Hopefully they run the triple panel of surface antigen, core antibody, and HBs and antigen to HBs. Then the lab reports the results to the doctor, and the doctor has a follow-up appointment with the patient to let them know of their results, if they're positive or negative. Now, even if they're positive, Delta is very rarely tested for immediately. And so there's usually a large time lag in between these. So what happens often is if the doctor suspects that someone is living with hepatitis B, might have Delta, so based on other laboratory findings, Then they'll say, let's take another blood draw and we'll send it to the lab to get the anti-HDV results. Now, if that result is negative, of course, the doctor will just tell the patient, but some even stop at anti-HDV and will just do the anti-HDV, let the patient know, hey, you're Delta positive, but not go any further. Then, if they are positive, some doctors will report this back to the patient, say we should really see if you have active disease, still do another blood draw, go to the laboratory, where it once again goes back to the doctor, and finally back to the patient. So there is many steps here. Each of these steps takes time, requires patients to be coming in for follow-up and overcoming any challenges there might be to accessing care. And a lot of this really depends on the doctor and their knowledge of hepatitis B and Delta as far as what tests they'll run and when. So when we say reflex testing, what we mean is it is all based in the lab. So you have the first appointment where the doctor says, hey, we have reason to suspect this person might have hepatitis B. Let's draw some blood and send it to the lab. So it goes to the lab, they do the triple panel. If it's positive, it is automatically tested for anti-HDV. And if it's positive for anti-HDV, then it's immediately tested for RNA, HDV RNA positivity as well. And all of these results will go back to the doctor, who can then consult the patient on the full results of their screening, wherever it may stop. So if they were surface antigen negative, that would be the end. If they were anti-HDV negative, that would be the end of this cascade. But even if they were positive and then negative, they're able to report to the patient in one visit the results of their labs, and then work together to come up with a treatment plan. So a lot of times when we model, we really, things look very complicated, but often they can be simplified. And that's similar here with reflex testing and the cost of reflex testing. So the only people who would be really impacted, excluding, of course, if we went back through the registry, which we really should do, is go back and test everyone within a national registry for Delta at least one time, just to understand that. But if we look moving forward, the main cost is going to be among newly diagnosed. So the cost of reflex testing is really just the cost of anti-HDV prevalence among those who are newly diagnosed for hepatitis B, and then the cost of an RNA prevalence for those of this group that were positive for anti-HDV. That's the total cost of the reflex testing. Now, globally, this would be relatively small. There's about less than 2 million individuals who are newly diagnosed globally, with almost half of those were occurring in China at the time of this analysis. So in high-income countries, there would only be about 114,000 anti-HDV tests needed to occur annually to implement reflex testing going forward. It's only 22,000 in all of North America. So we're able to see just from this that the costs actually would be quite modest. However, it is extremely dependent on the burden within the country. So it becomes more cost effective when there is a moderate to low B prevalence and any anti-HDV prevalence, because you're going to have low numbers of patients being diagnosed for B. And so there's just going to be fewer individuals in need of screening for the Delta. Where the math gets trickier and does require more complex analyses and modelings is if there's a very high B prevalence and a low Delta prevalence. So what we see in a lot of East Asia is a very high B prevalence, although it's been decreasing as a result of vaccination, and a quite low Delta prevalence. And so that's where the analyses really need to occur. Now, if we look at this bubble chart, what you see is the circles show how many RNA positive cases we estimate are in a country. And the left side is showing the hepatitis B cases, and the x-axis is showing you the anti-HDV positivity. So we see that with the exception of these countries that are have very low Delta prevalence, but relatively high B prevalence, it's a no-brainer essentially to be doing reflex testing. Now, one way to think about this is how many individuals do you need to screen to find new cases? And so a great example would be looking at South Korea and the United States. So in South Korea, if they screened every new B diagnosis in 2020, that'd be almost 20,000 individuals screened. And in the US, there would be about 12,000. So once you apply the Delta prevalence to that diagnosed population, and then from that, you apply the RNA positivity, what you see is in Korea, you screen almost twice as many people to find 13%, so about 1/10 of the number of positive cases because their prevalence is so low. So starting from the 20,000 and 12,000, you end up with 30 and 230 newly diagnosed cases. So this is just showing an example of why it's important to understand the disease burden and to do cost effectiveness where you have to screen a lot of people to find one case, which is another way, of course, to look at this. So this is the number of anti-HDV tests needed to find one positive case in the general hepatitis B infected population by country. So what you see, it's extremely high. You have to test almost 700 individuals in Hong Kong to find one positive Delta case. Whereas in Mongolia, where the prevalence is high, you might only need to screen 2. And so this is also another way of looking at what essentially becomes a threshold of almost 100 is the threshold as far as where it makes sense to do reflex testing immediately and where further analysis should be done to just make sure that this is a good intervention for the country. Now, there have been studies, of course, showing what is the impact of introducing reflex testing. So this is a study from Spain in which they looked at reflex testing in implementing reflex testing in their center and before and after. So what you see is prior to reflex testing, there was about 1,500 people screened, and they only tested 114 of them for Delta, and only 11 were found positive. Now, when they did reflex testing, they screened half as many people and ended up with about 5 times as many positive cases just by screening everyone with reflex testing in the central laboratory. Now, what was extremely important from this study is that 60% of the patients that were found to be anti-HDV and RNA positive had no risk factor, which means if there had not been reflex testing, they would not have been found until they progressed to later stages of the disease and were then tested later for having high levels of ALT or cirrhosis. So risk factor screening is suboptimal, and the reflex testing, as you can see, can immediately have an extremely large impact on diagnosing cases and then, of course, linking these individuals to care earlier. So as we've discussed ad nauseum, I suppose, is that there is very little quality Delta data in most countries, but we are able to find some data in every country that can help point us in the direction of where their burden is. And it's really good to understand what are the specific risk groups regions and ages in which it might be the most prevalent. Now, we also know that due to the faster disease progression, we'd expect lower prevalence in the oldest ages, but as a result of vaccination, we'd expect lower prevalence in the younger ages. So we're essentially ending up with a bell curve showing of where the Delta is, but this is greatly impacted by when countries rolled out vaccination, how quickly they scaled up to high levels of coverage, as well as when timely birth dose was introduced. So to finish up, what we do know is that no countries are currently doing reflex testing, but almost everyone we talked to said, yeah, we should be doing this. We agree. And as we discussed, most settings, the cost would be highly limited. Now, what would be great is this would also actually greatly increase the available data to understanding Delta within a country if reflex testing occurred. And while this would still be somewhat biased because an individual would have to be found positive for B, and they're likely going to be found positive for B as a result of seeking out care or having some sort of risk factor, it would be less biased than the current standards that we're resulting in with a very complex back and forth with the patient, the doctor, and the laboratory. And of course, the most important aspect of this would be the earlier diagnosis for these patients and working to help link them to care. So I know I went a little quicker than I meant to, but I'm very happy now to answer any questions.
Thank you so much. That is such a wonderful presentation, and your data is really remarkable and so detailed and helpful for each individual country. So we really encourage any audience members who have any questions to please put them in the Q&A box. But I'll kind of start out. I'm just wondering what you see. So it seems like a lot of people are, or a lot of countries are interested in this and agree that there's a need for it. What do you see as kind of the next step for getting something like this implemented? I know, like in the United States, for example, we've had conversations with about trying to make Delta reportable and notifiable, which the reason we're often given for why that hasn't occurred is because there's not enough data to support the need for it. So it's kind of a catch-22. So implementing this sort of reflex testing would, I think, go a long way to providing that kind of data. But there's kind of what do you think is needed to kind of push the implementation of this sort of testing?
Certainly, I mean, to your point, just really getting it notifiable would be huge in the US, of course, and just getting there to be more of an awareness and focus about it among providers, because of course we have our own challenges with patients, but really getting that with providers. And oftentimes the economic argument can be easy to make for them. And then with the doctors, you can make the argument that it's less work for them. Like, hey, you don't have to keep seeing these patients and making these decisions. Just send it to the lab once and the lab will take care of it all. And then you'll get the results and you don't have to, you don't actually have to learn a lot more about Delta to be diagnosing cases of Delta. And then if you're not comfortable with dealing with that patient, you can refer to them to a specialist who is. Did that answer your question?
Yeah, absolutely. Thank you so much.
Sure.
And I know also that so the treatment Hepcludex for Delta is, slowly becoming more available in more parts of the world. Do you think that might have perhaps part of the resistance is that it's viewed that there's not much that can be done for Delta patients, just because the only treatment thus far has been interferon, which has been, has a lot of side effects and its own complications. Do you think that the more widespread availability of Hepcludex and other medications would perhaps serve as an impetus for doing more widespread testing, or would that have any impact?
I believe it would have an impact. It could cut both ways, could be the problem, is
Mhm.
if countries saw it as an expensive treatment among people they currently don't know they have it, and then suddenly they have it and you have patients asking for it, they could see that
Mhm.
as an increase, which I think that's where the cost effectiveness gets into as well, as far as not just the countries with a high B burden and a low Delta burden, but in all countries to show, okay, you are really able to lengthen people's lives, continue to have them be happy, productive members of society. And this has a very large impact societally. But their gut reaction, if the drugs are expensive, will be, oh, it might actually turn some of them off from wanting to do it, if that makes sense. But I think you're totally right as well that for some people, it's like, oh yeah, we don't have to do interferon anymore. That's great.
Mhm.
We just don't ever get the headlines yet. I know you guys are working hard on it, but of having a cure like C did, where then
Yeah.
it's like, okay, let's just do this because we can eliminate it. It still becomes longer term treatments, which for some reason people are more uncomfortable with.
Yeah, yeah, absolutely. Yeah, I think having the cure will definitely go a long way for sure. Um, and then I know that there's folks joining us from Africa. There's a couple of people who've introduced themselves in the chat. So just and I know, especially sub-Saharan Africa is carrying one of the heaviest burdens of B in the world. Any kind of just thoughts on any specific challenges in that context too? I know I think I'm not sure about the Delta prevalence or if there's how robust the data is in these countries, but any thoughts you have on implementing this kind of testing in the African context specifically?
Certainly. So within the African context, there is some data available. There's less, and often with Africa studies, there's a lot of data among HIV positive cohorts for
Mm-hmm.
essentially any disease, because that's where a lot of the funding is. Now, the good news about Delta is there has been a lot of alarming studies out of Africa showing very high prevalences. And actually, just back at EASL, I saw some posters on it, and I was greatly relieved to see that they were, I forget which country it was now, but it was like a 16% Delta prevalence. Like, oh, this is terrible. And then you looked and it was among cirrhotics and people
Mm-hmm.
with liver cancer. And it was like, oh, this is great. Okay. It's actually comparable to many other countries, or not great. I mean, it's terrible for those people, but that it's not significantly higher necessarily. Now, I think more research needs to be done into that. And in regards to implementing it, I think the key in most low and middle income countries is tacking all of this on to the elimination of mother to child transmission. So looking at the triple elimination, and then also tacking on as much as you can to HIV, because the truth is that's where the current funding is. And so making arguments of, hey, we need to make sure we know what's going on. So we need to screen the mothers for B. And if we do the reflex testing, then we'll know about Delta as well, at least among the women who are getting pregnant. And then we can vaccinate their family members and their contacts as well and bring them in to do it. So I think that's where the most leverage is in Africa, is really focusing on, if you screen the mothers, you're going to be able to find a lot more positive cases and work towards triple elimination. And then from there, continue building up capacity.
Yeah, absolutely. I think that speaks a lot to the need to integrate multiple diseases together for sure. Great. Well, if there's any questions from the audience, we would love to. I know that there's some folks who are joining who do a lot of grassroots advocacy work and do a lot of Hep B screening in their context. So if you have any thoughts on hepatitis delta or how this kind of testing might work in your context, please feel free to throw them in the Q&A box. And I kind of had just one more sort of thought, and I know there's still research being done into sort of why Delta prevalence seems to be more common in particular geographical regions. I think some of it might have to do with particular genotypes. But do you know sort of why, for example, the Amazonian River Basin and Romania and these kinds of places seem to, why they do seem to have these sorts of higher prevalence, or any thoughts?
So I think something that's very interesting in the Amazon is it once you zoom in from the region, so there'll be studies in the Amazon that actually look by community. So they'll look within indigenous communities as well as among, they call them ribeneros, like people who live next to the river in the Amazon but aren't necessarily indigenous.
Okay.
And when you look at the studies at that detail, there's actually certain communities that have extremely high prevalence of B and others that are quite low, and similar with Delta. So it seems to be extremely localized in many cases. And some of that could just be due to cultural practices, though with the Amazon, I've actually talked to some of the Brazilian professors, and they said that they've actually been able, there's these very sharp plants that are on the pathways, and you'll get cut by them on your leg as you walk by. And they've actually found viable HDV RNA on them. And so they actually think that's part of it, is it's just, so sometimes I think it could just be the strangest of risk factors we never consider. But I think it's really about it getting established. So once it gets established high in a community, it's going to be able to maintain itself better than if there's only one person and it doesn't spread much or so.
Sure. Yeah, that makes sense. Yeah, I think I've seen some literature coming out recently about Delta's sort of plant origins, which is fascinating. So yeah, that's very interesting. We do have one question. Looks like Adesua is asking, so the double reflex testing is about testing for HBV and HDV for people living with HBV. So yes, I think that's correct. If you want to maybe just quickly reiterate the RNA and antibody sequence.
Exactly. So if someone already has hepatitis B and knows of their infection, so people living with hepatitis B, it would be fantastic if governments would go back and test all of them for Delta. And then in the laboratory, if they're anti-HDV positive, it'll test them for RNA as well to see if they are eligible for treatment and if they have an active infection. Now, moving forward, what we'd like to see with reflex testing is at the laboratory, as soon as a blood sample is found positive for B, it automatically goes to Delta. And if it's positive for anti-HDV, it automatically goes to RNA as well at the laboratory. So no one has to do it. So that way, it's not only for people who are aware of their status, but it's for people who are learning newly of their status as well.
Absolutely. Thank you so much. Yeah, I think, and this would alleviate a lot of the burden from physicians who are doing the testing. If it just, so reflex testing just means it's automatic and that the lab takes care of it right away after seeing the test results. So you don't have to keep calling in new blood testing orders. Great. Well, if there are no other questions, I so appreciate your time today. Thank you so much. And I think we will, Fiona, would you mind please sharing our final slide? Thank you very much. We want to thank so much Dr. Razavi-Shearer for joining us today. And we really appreciate all your time and insights about this really important topic. And thank you so much for everyone for joining today's webinar. We hope that you found it informative and valuable, and that you can apply some of what you learned in your work or life going forward. We will have an evaluation form once the webinar concludes, which we encourage you to complete. Your feedback is really important. And again, a recording of the webinar and slide presentation will be emailed out to all attendees. We also encourage you to sign up for our Hepatitis Delta newsletters, which are both we have one for providers and one for people living with or affected by hepatitis delta, and you can be added to our mailing list to receive regular updates about Hep Delta drug development, clinical trials, research, news, and events like this one. And you can find the links to sign up for the newsletters in the chat, and these will also be emailed out after the presentation as well. And we encourage you to reach out to us using the contact info on the slide to get more information about our programs or follow up on the topics of this webinar, and to visit our website for more information. So thank you so much again, Dr. Razavi-Shearer, and thank you everyone for joining. We hope you have a wonderful rest of the day.
Thank you.
Thank you. Take care.